It is my great privilege to welcome you to Conversations about Colorectal Cancer. Hearing the words, "you have cancer," can be paralyzing. You are hit with a major emotional shock, and in the same conversation, you have your first introduction to the vocabulary of cancer: resection, ostomy, neuropathy. If you aren't careful, you get thrown into the big, complex cancer machine with little idea of what is happening to you or why. And the emotional trauma makes it harder than ever before to ask questions or to understand the answers. For people with colorectal cancer, this becomes even tougher. You are fighting a disease that affects a part of the body that most people don't discuss. The very nature of colorectal cancer can make it more isolating. Yet one thing is clear: being informed and having a strong community of support are critical factors in living longer and better. That is why we are encouraging people to have conversations about colorectal cancer. Over the past year, we have traveled across the country to give patients and their families the latest and best information about treatment options, and to let patients and their families know that they are not alone. We are pleased now to bring you this information on the web. I want to thank the wonderful doctors of M.D. Anderson for sharing their expertise in this seminar, and to thank Amgen for their generous support that has made this event possible. And finally, I want to thank Joan London, whose insight and compassion you will find evident as you watch. Please take your time in viewing this material, and call the Colon Cancer Alliance if you have any questions. This seminar series is made possible through support from Amgen, so we're glad to have you here, and we certainly appreciate the support we've gotten to help make this information available to patients across the country. Now it is my great privilege to introduce someone who you all know. Joan London is probably the most recognized and trusted face in television journalism today. She spent almost 2 decades in Good Morning America, helping everybody wake up and start off their day well and informed. She is currently the host of Hometown Heroes on DirecTV, and will host a new program, Health Corner, on Lifetime that starts January 4th. So a whole new venture for her in this area. She's a speaker and an author. She's written a number of books, including a series of books about how to live healthy and well, a great cookbook on healthy cooking. But you know her, and I'm going to introduce her now. Joan London, thank you so much for being here.
The Conversations about Colorectal Cancer, Finding Hope in Your Community National Tour, really came about because of a need that was expressed by colorectal cancer community members, that they needed a way to be able to really hear from the experts and to be able to connect with each other, and to just help them manage their own health care. The fight against cancer is a difficult one, and the fight against colorectal cancer often leaves patients feeling overwhelmed by just the choices that they have to make in treatment options, and also isolated. So these seminars have really been uniquely designed so that the attendees get a chance to hear from the leading colorectal cancer health professionals in their area, learn about the latest treatment advances, be able to ask questions of the experts, and then also be able to interact and have that participate in that peer-to-peer forum. The events we found have really allowed patients to, and also their caregivers. A lot of you here today are probably also caregivers. It just gives you that opportunity to get together and share your experiences and learn from one another, and also just be able to support one another in the battle against colorectal cancer. We are additionally really working hard to just increase public awareness about the importance of talking about this disease, and the importance of that open dialogue between patient and doctor. Because in this country, we know that most Americans don't talk to their doctor about colorectal cancer. And sadly, we also know that if it's caught early, it's one of the most treatable forms of cancer. Information. Information is really one of the most important tools in fighting disease, and especially, of course, in fighting this disease. The Colon Cancer Alliance has been doing these seminars now for 2 years with the very generous support of Amgen. And they've been told by a lot of the attendees that these seminars have been life-changing events for many people. And we really hope that you will feel the same way at the end of today. We hope that you leave with the feeling that you've made some new friends and that you have also found a new source of support in your community as you go through this journey. The Colon Cancer Alliance has worked very closely with the doctors here at M.D. Anderson Cancer Center to bring you speakers that are really leading experts in their fields. And they will provide you with the most up-to-date advances in colorectal cancer treatment information in oncology and in surgery and in interventional radiology.
Despite what many individuals think, colorectal cancer is not an inherited disease for the most part. Most patients develop it sporadically. Inherited forms of colorectal cancer only represent a very small minority of the individuals that are diagnosed. And actually 75% of patients do develop disease as a result of sporadic development. So how does this all begin? And basically here is the transition from the formation of a polyp, which is basically a benign growth, and then eventually it becomes cancerous. And it's just to give you an idea about the changes that occur over several years that results in the development of colorectal cancer. And one of the leading things I'll be discussing is this mutation here called KRAS, which is basically one of the newest advances regarding colorectal cancer research and how to tailor your therapy a little bit better to your disease. And this is really the transition. Many patients ask me, how long have I had this? How long was it present? And in actuality, the difference from a polyp to becoming a carcinoma or an adenocarcinoma takes anywhere from about 5 to 10 years. And so that's why it's very important individuals get screened. And the standards age for screening for a patient without any inherited risk factors is supposed to be 50. And many individuals maybe were not notified by their physician, or they feel well and they did not think about going to get screened, but it is a standard screening procedure and the average age is 50. If you have a first-degree relative that was diagnosed, you're supposed to be screened 10 years earlier than their diagnosis. And obviously those individuals that have a familial history of getting colorectal cancer should be screened much sooner. This just gives you an idea about the anatomy of the colon. And when we discuss with our patients if you have a right-sided tumor or a left-sided tumor, if you have a rectal cancer, this basically is the distribution of where most of the colorectal carcinomas develop. And the reason that we recommend you get a colonoscopy is because the colonoscopy goes all the way to the right side of the colon. And if you get a flexible sigmoidoscopy, you're going to miss those 30% that are on the right side. So it's very important that you get a colonoscopy. That's the standard of care for screening. So another question that I often get is, what is the stage of my cancer? And basically we grade stage by the degree of tumor penetration through the muscle layer. And this is just the T stage, and that's just part of our staging system. That doesn't include your lymph nodes, but basically it's very important to focus on if there's penetration through the muscle or if there's invasion into the adjacent organ, or if your tumor had perforated or ruptured, which is what's called a T4 tumor. And that's a much more a high-risk tumor. So some important definitions I'd like to discuss with you just very briefly. When I state adjuvant chemotherapy, that is chemotherapy that's been provided after surgery has been completed. And the reason that we provide it to patients is to decrease their risk of recurrence. And metastatic disease is equivalent to stage 4 disease. And so those are just a few of the terms that I'll be discussing, and I'll focus a little bit more on the early stage setting and then focus on the metastatic setting, which is where most of the advances in our therapy have been lately. So what are your options for colon cancer? And I stated before, it's dependent upon your stage. After surgery, stage 1, usually it's just observation only. Stage 2 means that there was penetration through the muscle, possibly, but there was no lymph node involvement. And there is consideration for additional chemotherapy for so-called high-risk patients. And I'll be discussing that very briefly. And then for stage 3 patients, those are patients with lymph node involvement. And those patients, it is recommended you undergo 6 months of adjuvant or additional chemotherapy after surgery to decrease your risk of recurrence. For stage 4 patients, chemotherapy is usually our best treatment, and the duration is variable depending upon the degree of tumor involvement. Surgery may or may not be considered. It may be considered if you're having symptoms or if the site of disease involvement where your tumor has spread can be surgically removed. And you may or may not consider radiation therapy, once again, also if you are currently having symptoms or possibly just for local control of your therapy. So why do we give chemotherapy to our early stage patients? As I stated earlier, stage 1 patients, we don't provide any additional therapy. Usually the surgeons just follow the patients. But for stage 2 patients and stage 3 patients with lymph node involvement, we want to reduce your cancer recurrence risk. So what are your options for therapy? Well, 5-FU is a drug that's been around for over 50 years, and it's utilized in other cancers, but it's really the foundation of our therapy for colorectal cancer. And the reason I bring this up regarding early stage disease is that we automatically recommend additional chemotherapy if you have stage 3 cancer based upon this very large study that was conducted involving a little less than 1,300 patients. They noted after a follow-up of 7 years, if you had stage 3 colon cancer and received additional chemotherapy, it reduced your risk of recurrence by 40% and a 33% reduction in your mortality. And now we actually have a newer drug that is available that we add onto your chemotherapy regimen called oxaliplatin. So some of you may say, you've heard of this so-called acronym called FOLFOX, and we utilize that also in advanced stage disease. The reason that we provide it to our patients for stage 3 colon cancer is that in comparison to just 5-FU alone, we now know that if we give you the full combination of chemotherapy for 6 months, which is the standard of care, it decreases your risk of recurrence by 22% versus just getting 5-FU alone. And FOLFOX, oxaliplatin, and 5-FU, some of you may be familiar with this, is considered now the standard of care for stage 3 colon cancer and is also utilized in stage 4 disease as part of the foundation of our therapy. Now, I mentioned those kind of high-risk patients, those that have invasion of another organ, those that had perforation, those that may have not had good enough lymph node dissection. Well, you may want to consider giving those patients also additional chemotherapy. I mentioned in early stage cancer, we basically only have 5-FU and oxaliplatin, but for stage 4 colon cancer patients, we have various combinations based upon these drugs that are approved, and all of them have been primarily approved since 2002. Prior to that, really 5-FU was the only drug available for our colorectal cancer patients. And so these are the standard chemotherapy drugs, but now we have really interesting drugs that are not chemotherapy agents, but are so-called targeted therapies. And so some of you may be familiar with them. Bevacizumab is also known as Avastin, cetuximab is also known as Erbitux, and panitumumab is also known as Vectibix. And one of the more greater advances is the fact that we actually may be able to tailor your chemotherapy based upon your own underlying tumor biology. So for stage 4, our treatment options, we have various chemotherapy combinations, as I mentioned earlier. And 5-FU is still the foundation of all of our therapy. We may combine it with another drug called irinotecan, and you may hear us call it FOLFIRI. Or we may combine 5-FU with oxaliplatin, and that's called FOLFOX. Or we may take the oral form of 5-FU and combine it with either of those other drugs, as mentioned above, and those combinations are mentioned there, called Xaliri or Xelox. But any of the above may or may not be combined with targeted therapies if we feel that you're an appropriate candidate for these agents, as I mentioned earlier. So previously, up until this past year, we thought that we had to provide all available chemotherapy regimens to our patients in order to prolong your survival as much as possible, as long as you were tolerating it. And it didn't matter which sequence you went. We understood that as long as you were feeling well and you were able to tolerate your therapies, we would be providing you various chemotherapy regimens, and that would prolong your survival as much as possible. But now we have these so-called targeted drugs, and we have 3 FDA-approved drugs. Now, I mentioned Avastin. And Avastin is a very different type of drug. It's an anti-angiogenic agent, meaning that it works on the blood supply of a tumor. And a tumor needs a blood supply to grow, survive, and metastasize. Now, another mechanism that's very important in colorectal cancer is what's called the epidermal growth factor family. And the reason I mention this is because these two drugs, cetuximab and panitumumab, also known as Erbitux and Vectibix, block a receptor in this pathway. But can we predict who will respond to Avastin? And unfortunately, not yet. We have evaluated markers in both blood and tissue, and yet we have not been able to determine which patients will definitely respond to Avastin. However, it's tolerated extremely well, excluding the high blood pressure, which is easily treated. Now, I mentioned those other two drugs, though, the other pathway, the epidermal growth factor receptor pathway, which can cause a pretty significant rash, but it's a very important pathway also in colorectal cancer. It's actually the first step towards personalizing therapy. This is one of the most recent research advances that have occurred. I just want you to get an idea how important these two drugs are, because either cetuximab or panitumumab, when they're provided to patients, it blocks this one receptor, and that one receptor blocks multiple other pathways, but they're involved in tumor survival, and also results in cell death. It also prevents metastatic disease and invasion. So I just want you to understand how important this pathway is in colorectal cancer. So what's the reason that we would consider cetuximab or panitumumab for you? Cetuximab was approved, and it's basically for those patients that have progressed on therapy that involved irinotecan. Some of you may know that as Camptazar. Once again, it can be used by itself, and it's approved in use in combination with chemotherapy. The same thing with panitumumab or Vectibix. Currently, it's only approved to be utilized by itself, but it is also utilized for those patients that are allergic to cetuximab. And the reason why it's really important that maybe we can predict which patients will respond to this therapy is because of these side effects. A very significant rash, predominantly of the face, the scalp, the upper torso, and then you can get inflammation of your nail beds, and you can actually get what we call fissuring, which are cracks between the nails beds. So it can be quite painful. And this rash usually develops the third week of chemotherapy administration, and it's present throughout all of your therapy. So if we can determine which patients would benefit from using these drugs, rather than providing it to all patients up front, then we can assist them with that. So what's really important nowadays is we actually have been determined if there's a mutation that's present in patients. And one of that mutation I mentioned before is called a KRAS mutation. And it develops in the early stages of colon cancer development before the more advanced stages. And why is it important? Because if this was a study actually conducted looking at the use of panitumumab versus just what's called best supportive care, or just watching and observing the patient. If you have the mutation, you don't derive any benefit at all from this drug. And actually, some studies have shown that it actually may be more detrimental to you if you have the mutation and you receive either cetuximab or panitumumab. So that's why we test all of our patients now for this mutation if we are to consider these drugs. And actually in the UK, it is mandated that it must be conducted and completed before even considering using these drugs. So what can you do as a patient? You need to communicate to your doctor. You need to follow up with your appointments appropriately. Notify your doctor about any potential herbal supplements. Good family and social support are very important. Exercise is very important in maintaining a healthy quality of life. Work if you enjoy work. You should continue to do everything you normally do. And your quality of life, including your sleep habits, as well as sexual activity, should be discussed with your doctor. And I know a lot of people are very shy about discussing sexual activity, but it's part of your quality of life. Colorectal cancer is not to consume your life, but it's really a part of your life, and I think it's important for patients to recognize that. So in summary, screening continues to be underutilized in colon cancer. Colonoscopy is the gold standard of care, and the majority of colorectal cancer is sporadic. You should keep that in mind. KRAS is the first universally accepted molecular marker, and the KRAS mutant tumor type patient should not receive anti-EGFR therapy because it will provide no additional benefit. And it's very important to think of colorectal cancer now as more of a chronic disease. It's important to realize that you can live with this disease. And it's very important to participate in clinical trials if they're available to you, because every single drug that is approved went through 3 phases of a clinical trial before it received FDA approval.
Surgery for colon and rectal cancer. Very important to recognize that surgery is the primary modality for curing patients with colon and rectal cancer. I don't say that just because I'm a surgeon. But in fact, it's been well proven for decades before we had effective other treatments. Certainly for early stage disease, and that is unfortunately the minority of patients that we see presenting with colon and rectal cancer, it is the only therapy required. That has just such huge advantages for the patients in terms of not needing to undergo toxicities of other treatments beyond the surgery. And in fact, obviously it's the fact that it's an early stage of disease that means that they're likely to be long-term survivors. Certainly adjuvant therapy in the form of chemotherapy and radiation for properly selected cancers increases the likelihood of cure. In fact, these therapies apply to most patients who present today with colon and rectal cancer. However, those therapies do not make up for inadequately done surgery. And in fact, unless a patient is treated curatively with their surgery and completely, these adjuvant therapies are unlikely to benefit them in a great deal. We need to make screening easier for patients in order to be able to see patients with earlier stage disease. The patients who have colorectal cancer frequently require multidisciplinary care in order to have an optimal outcome. It's not simply they're going to be treated by one discipline and that's going to be it. This is an example of Dr. George Chang doing laparoscopic surgery with one of our fellows, and it's been shown that such surgery for properly selected cancers, not necessarily all colorectal cancers, can result in very low hospital stays and a reduction in the use of pain medication, and in some instances a quicker resumption of normal activities than our standard open surgery, without any compromise when the patients are properly selected. The ability to harvest greater than 12 to 14 lymph nodes and examine them has been shown to be associated with a better survival across just about all the stages of resectable colon cancer. It's a very important and increasingly recognized fact that colorectal cancer can be an inherited disease. And in fact, we may not understand all the ways that it's inherited yet, but there are certainly instances where we do recognize well-described syndromes. Not every patient desires to have genetic testing in order to establish whether they have an inherited syndrome or not. There are certainly still fears about insurability and discrimination related to genetic testing that should be dispelled. But that's an individual decision. Colon cancer is different than rectal cancer. And that is something that is often lost when patients turn up in the clinic and nobody's explained to them that the management of rectal cancer is more complex than colon cancer. Once the clinical staging is done, and by that we mean the staging that relies upon testing such as CT scans of the chest, abdomen, and pelvis, as well as a test called an endorectal ultrasound that tells us the depth of penetration of the tumor and whether or not there are already enlarged lymph nodes around the cancer, as well as the presence or absence of distant metastases. We can come up with a clinical TNM staging. And based upon that initial clinical staging, a treatment plan is devised. If it's a very early cancer, then surgery alone can be used. If it's a stage 2 or 3 rectal cancer, patients will receive preoperative chemotherapy and radiation. And that's before we have a specimen or a pathology report that comes back and says it's such and such a stage. So it's really important to understand that in rectal cancer, the clinical staging is what drives the treatment. This is an example of how the treatment of rectal cancer differs from the treatment of colon cancer. Still requires surgery for curative therapy, and then patients may go on to other additional treatments if indicated by their stage. This is the most common operation done for rectal cancer. It's called a low anterior resection. Those patients avoid a permanent colostomy. It's a pretty straightforward deal. However, the truth is that many of our patients have tumors that are lower in the rectum. Now, overall, greater than 80% of patients who present with rectal cancer are going to be spared a permanent colostomy. So the idea that someone should be afraid to deal with symptoms or go to the doctor for rectal bleeding or a change in bowel habits out of fear that they're going to end up with a permanent colostomy, that really has to be dispelled among the public. Many times in years past, if the tumor could be felt on rectal exam, which means that it's roughly anywhere between 0 to 5 or 6 centimeters from the anal verge, from the outside, those patients would be treated automatically with what's called an abdominal perineal resection, which is an operation that adequately removes this cancer, but ends up with a permanent colostomy. That is markedly different today than it used to be. Markedly different. By the use of preoperative chemotherapy and radiation, tumors such as this can be converted after the chemotherapy and radiation to a tumor that is lower in volume and smaller. And what that allows us to do is it allows us to do a much more sophisticated low rectal cancer operation that restores the patient's continuity of their GI tract and avoids a permanent colostomy. And because of that, the patient's quality of life is going to be improved after this care, and they can get on with their lives in a more normal fashion. Of course, for patients who do require a colostomy for adequate removal of their tumor, there is no question that that is what should be done. And in fact, those patients will go on to have an amazingly good quality of life in almost all instances. This is an example of an operation that is probably the most common one that I do. This is called a proctectomy and a coloanal anastomosis, where the rectum is removed down to the top of the anal canal. Then we go through the anal canal and cut the rectum free, assure the patient that they have a clear margin, and then the GI continuity is restored by bringing the colon down into the anal canal and either sewing it directly into the anal canal end to end, or making a J-shaped pouch that increases the reservoir function of the rectum and can somewhat reduce the bowel abnormalities that are produced by this sort of surgery in an effort to improve the patient's quality of life. So we're not giving up any aspect of the cancer control in order to do sphincter preservation when it's done appropriately and with the use of preoperative adjuvant therapy. What about patients with metastatic disease? That's an important thing that Dr. Eng started to address. This is an algorithm where patients go from the diagnosis of liver metastases. Some patients are unresectable and go on to the treatments that Dr. Eng outlined. Others, however, will, if they're immediately resectable, they can go on to some systemic therapy first in order to prevent progression in other organs. I mean, why do patients die of colorectal cancer? They die of colorectal cancer because of distant metastases almost all the time. It's not due to the primary tumor in their GI tract. And control of those distant metastases has advanced greatly in the last 7 or 8 years. While surgery remains the definitive component of curative treatment, even patients with metastatic colorectal cancer can benefit from surgery either due to reduction of their tumor and potential increase in survival, as well as relief of symptoms, and therefore they may have an improved quality of life. This is an example of a patient who had bilobar liver metastases, treated, had 16 different tumors in 7 of 8 anatomic segments of the liver, went on to have chemotherapy to reduce the sizes of the tumors, go on to have actually 2 operations to remove their liver metastases, and then you can see their normal liver has grown back here after the resections. Another technique that's used is ablation, which is the use of radiofrequency to ablate these tumors. One more example of how our liver surgeons are always doing something. This patient has a very small left lobe of their liver. You need a certain volume of liver left in order to survive. And in this case, what they did is a portal vein embolization, which is blockage of one of the blood vessels to the left side, hypertrophy of the liver because of that blockage. That allowed them to then do the resection of the portion of liver bearing the tumor, leaving enough viable liver for the patient to survive and do well. Last example of treatments for metastatic disease. This is for patients who have disease spread on the lining of the abdominal cavity. This is a form of perfusion of the abdominal cavity after debulking those tumors. It's perfusion with a hyperthermic solution containing chemotherapy that can get to all the surfaces on the lining of the abdominal cavity.
Interventional radiology is really the cutting-edge technology, doing everything minimally invasive, not needing surgery as much as you can help it. So, having said that, I want to start talking about liver metastases. That's one of my interests. That's where interventional radiology has made a great impact in the care of patients with colon cancer. Unfortunately, half of the patients with colon cancer will develop liver metastases at some point. The liver sits in the upper right side of the abdomen, an area where we call right upper quadrant. Now, it surprises me that I see patients in clinic and they have never seen their CT scan or an MRI. They might have had many, many CT scans. And I sit down with them and I say, have you seen your CT scan? Do you understand the images? And the answer often is no. So I thought I'd take this opportunity and kind of show you how to look at your images and how to get involved in terms of directing or helping guide your therapy. I'm showing you a normal CT of the liver. This is a cross-section of this patient liver that sits in the right upper quadrant, and we're looking at a cross-sectional image. By contrast, you don't have to be a radiologist to look at this liver and notice all these dark spots all throughout both lobes of the liver. This is a patient who has metastatic colorectal cancer. We use both PET scan, PET CT scan, and CT scan, and at times MRI, to help us find these lesions in the liver. And once we find them, we need to treat them. And as Dr. Skipper said, and I firmly believe, and I'd like to make sure that you all understand, that the best treatment for localized tumor to the liver is surgical resection. The best 5-year survivals have been reported with resection of the tumor within the liver. A lot of times patients do not qualify for surgical resection. Only 20% of the patients will be candidates for surgical resection. Some of us are older when we get cancer, and those patients may have many other medical problems, may have heart problems, lung problems, or simply to be too old to undergo a major surgical resection for the liver surgery. Patients might have had previous liver surgery, and they may not qualify for an additional surgical intervention. Finally, patients may have extrahepatic metastases. That is, tumor has gone outside of the liver, outside of the colon, and let's say, to the lung or to the bone. This particular patient started her battle with cancer in 1977, many years ago. Over the years, she had many surgeries, but she survived all those recurrences and also those surgical resection. Now, in 2008, at age 92, she comes to us with excellent performance status. Very nice elderly lady who thought I was cute, so I like her a lot, actually. But so I see this patient in the clinic, and she has only a solitary lesion in the liver. Can we do anything for this patient? Probably not a good candidate for surgical resection because of her age. So we offered her percutaneous radiofrequency ablation. Now, radiofrequency ablation started in the operating room, but we have miniaturized this. We have simplified this so that patients don't need to go to the operating room, and the entire procedure can be done in the CT room when the patient is where some of you might have had your CAT scans. So the idea is, and this is the artist's rendition of how radiofrequency ablation is done. A simple needle electrode is placed within the tumor, and this is connected to a machine, and this unit generates enough electricity that causes heating of the tumor, a finite volume of tissue, and kills the tumor. It essentially burns the tumor, and the idea is to kill the tumor, not only the tumor, but also a margin of safety around that. Unfortunately, not everybody is going to be a good candidate for this form of technology or treatment. An ideal candidate with liver tumor would be a person who has a single liver tumor that is less than 3 centimeters. What about patients who have already had liver surgery? Certainly, repeat surgery becomes even more challenging for surgeons, So even though surgeons do consider repeat liver resection, the procedure may be more difficult and more challenging. So that's where we come in. And we do radiofrequency ablation for these lesions. We kill the tumor, but we don't take it out. So what it implies is that we have to watch the patient very carefully. So over the course of the year, we watch the patient, we bring him back, we get CT scan every 1 month to 3 months to 6 months over the course of the 2 years that we follow them. And then from there on, maybe once a year, we get a CT scan to show that this area that was not enhancing continues to shrink and does not enlarge. And that's the idea how percutaneous radiofrequency ablation is done. I think it's important to understand that most organs in the body have one set of blood supply that bring the blood into the organ, arteries. Let's consider your kidney, for example. The kidney has arteries that bring blood supply to the kidney, and then there's a set of veins that take the blood out of the kidney. The liver is different. The liver actually has 2 sets of blood supply that bring blood to the liver, and 1 set that take the blood out. So we're fortunate. That's how we can do a lot of vascular or intra-arterial or venous-directed therapy to the liver because we have 2 blood supplies to the liver. So what we do, we actually get inside the liver, and from inside the liver, we block some of these blood vessels. And what that does, it shifts all the nutrients to the other side of the liver, where the liver continues to grow and enlarge. This has been a major breakthrough for surgeons to be able to operate on a lot more patients than we previously could. Another scenario, too many metastases in both lobes of the liver. We take advantage of this dual blood supply to the liver. So this is the artist rendition of a tumor in the liver, showing you that the red, the artery, brings the blood supply to the liver, but also provides most of the blood supply to the tumor, whereas the portal vein brings the blood supply to the liver and hardly ever produces or supplies any blood supply to the tumor. So we can actually take advantage of getting inside this artery and either blocking it, giving chemotherapy directly into the tumor, or perhaps giving internal radiation to the tumor. One of the major problems with oncology is that we can treat cancer, and then we can do another CT scan, and we see the tumor is slightly smaller, but we don't know whether the treatment has been effective or not. That also holds true for chemotherapy. And that's where the PET scan or PET-CT scan has played a very important role to tell us whether this tumor that still exists in the liver, is it functional or is it not? And I think that's one of the major advances in terms of radiology. So again, going back, I think treatment of colorectal liver metastases, remember that best chance of cure is by surgical resection. And we have seen advancement in the field of liver resection, liver surgery, intraoperative radiofrequency ablation, preoperative portal vein embolization, and all of those are viable choices to get the patient who may not be a good surgical candidate to become a good surgical candidate. When all else fails and the patient may not be a good surgical candidate, then there are minimally invasive therapy options. We talked about radiofrequency ablation, which I call thermal ablation therapy. Other forms of energy are also available. People are working, investigators are working on more effective treatment options, thermal treatment devices, such as microwave. Other forms of energy, such as cryoablation, are available. Laser ablation, which we have started doing at MD Anderson, provides the advantage of actually performing the procedure in an MRI suite, which in itself is a huge technical advancement, being able to do all of these procedures inside an MRI suite. So that is something that will be coming along in the future. And then we talked about transarterial therapy. On that note, thank you for your attention.
Doctors, I will address a question to one of you just so we can kind of get it started, but please feel free to chime in and add anything else to it. I'll start out with a question that somebody here had for Dr. Eng. Are clinical trials just a last chance, last-ditch effort, no more options, having had gone through all the available chemotherapy?
That's a very important question, and I think it's important to recognize that clinical trials are not meant to be the last effort after you've received all standard chemotherapies. There are various stages of clinical trials, which I mentioned earlier, phase 1, phase 2, and phase 3. And there are trials for patients that are treatment naive, that have never seen prior therapy, versus one prior therapy versus multiple prior therapies, which usually is an earlier stage phase 1 trial where you're considering some type of very early in development investigational therapy. But the whole point of, if a clinical trial is available to you, you should consider participating in it and get a lot of information to see what it is in comparison to the standard of care that may be offered to you. Because all the drugs that we utilize now had to go through all these phases of clinical trial before it went to the FDA for approval. So without your participation, these drugs do not advance fast. And as a result, we do need your assistance in participation in clinical trials. It is not meant as a last resort.
What are the questions that you should ask your surgeon?
Well, that's a very broad discussion. But clearly, you need to understand, what the procedure is that they're going to do or that they're anticipating doing. And also, you need to be clear on why they're doing it. What are the goals of the surgical procedure? In some cases, that's going to be potential cure of the tumor. In other cases, it may be to relieve a specific symptom or problem. And that's a very important, I think one of the most important things is that everybody's expectations are clear. The other thing is it's really critical is an understanding of what are the options for management of the specific problem you're seeing the surgeon for. And usually there are options, all the way from not doing the surgery at a given time to performing a very radical procedure. And the surgeon who's taking care of you should understand what those options are, and especially in colorectal cancer, because the care is so often multidisciplinary, understand how that care, how his operation is going to integrate into the rest of the care to provide the best outcome for the patient. So I think those are important things. Obviously, questions like how many times have you done this? While they may be interesting to know, they really are simply, that's sort of a broad screening thing, and don't address somebody's particular expertise with exactly what you need now. Even if they're, not doing this just colorectal cancer surgery, there's often operations that our general surgeons are very well trained in and perform perfectly well.
How are the different treatments for liver mets determined, RFA versus others, and what is the cure rate for these?
Very good. That's a very good question. So we talked about thermal ablative therapies or minimally invasive therapies that at least we have available in our armamentarium of treatment options. We talked about radiofrequency ablation, but the same type of therapy can be performed with different types of energy, such as microwaves, such as lasers, such as cryoablation. Those are really technical issues that are probably beyond the scope of this discussion. I think it has to do with the expertise available at the center that you're being treated at or considered. If you were in Germany, in Frankfurt, I have colleagues in Germany that all they do is MR-guided laser ablation. That's all they do. If you're here at MD Anderson, more likely you would be treated with a CT-guided radiofrequency ablation because that's our expertise. We're trying to tap into other technologies. So the question as to whether you get cryoablation or laser ablation or radiofrequency ablation is really a local, regional issue in terms of where you're being treated. I think the more important question is that if that form of thermal therapy is appropriate for a particular patient. And I think that's what we talked about. You need to know the size of the tumor, the location of the tumor, and where it is, how many lesions you have. We talked about an ideal candidate who has a tumor that's less than 3 centimeters, and there is a solitary tumor in the liver. If you take that patient and take him to surgery, they will have a 5-year survival of anywhere from 50 to 60%, depending on who you read and what medical literature you review. The same type of patient treated with radiofrequency ablation can have a 50% 5-year survival. So if you have looking at a very limited disease, radiofrequency ablation is almost as good as surgery. But surgery, of course, provides the intraoperative ultrasound and assessment of other portion of the liver and a more aggressive form of therapy.
Dr. Ng, should a stage 4 survivor who has no evidence of disease have chemotherapy as a precaution? They go on to ask, do the possible benefits outweigh the long-term side effects, and what are the long-term side effects to chemotherapy?
It depends upon the stage 4 patient, whether it's because they're stage 4 and have no disease because they've had recent surgery and their tumor's been resected or their site of metastatic disease has been resected, versus somebody that the tumor went away just with chemotherapy alone. In general, we don't continue chemotherapy unless there's active disease that is noted on a CT scan, because we need to know what we're treating. So if you may, as I said before, you may receive some additional chemotherapy after surgical resection, but in general, for a stage 4 patient, we usually just place the patient at some point on observation only if there's nothing evident on CT scan.
What is the risk of increase in radiation from CT?
Well, I think what they're referring to is virtual colonoscopy versus colonoscopy itself.
Okay.
And it is true that these days virtual colonoscopy can be used for screening purposes. And colonoscopy itself, however, is the standard by which virtual colonoscopy needed to be good enough to be accepted as a screening tool. And there are advantages to and disadvantages to both. Certainly the radiation dose is an issue if you're going to have a screening test that's used frequently. Much the same is the situation with mammograms, actually. So that's one drawback to virtual colonoscopy. Of course, the other side is that it has a lower incidence of complications. You know, while the incidence of complications from colonoscopy is relatively low, and by that specifically we're referring to bleeding or perforation, it's not zero. And certainly if you look at the large number of people in the country that should be screened for colorectal cancer, even a very low incidence of complications could be substantial in terms of health care. So, you know, that's the downside of colonoscopy. There are some patients virtually who, in fact, cannot have colonoscopy. Typically, it's patients who've been operated on before and potentially had parts of their colon taken out, or they just have a very tortuous colon and it's a problem negotiating around that. Certainly for those patients, virtual colonoscopy is a big advantage in screening. They both still require the prep, however. So you're not going to get much of a difference in that. At this time, they both require a prep. So it's an interesting technique. It's certainly got specific things it's very useful for, and it holds the potential of you know, being more acceptable to the general population, and therefore maybe anything that causes more patients to be screened earlier is a good thing, and so it's another weapon in that armamentarium.
But if you have a polyp, you still need
colonoscopy.
Yeah, that's the only way it
to
can be
take out
removed.
the polyp.
Is there any research being done to relieve neuropathy as a result of oxaliplatin treatment?
Neuropathy is the limiting factor for the use of oxaliplatin. It ends up being a cumulative peripheral neuropathy that is reversible, but meaning that the more oxaliplatin you receive, the more likely you will develop peripheral neuropathy. There is some research using some homeopathic remedies such as acupuncture that are ongoing at some institutions, as well as herbal supplements, as well as a medication that's being investigated in Europe, actually, that has been created by Sanofi, who actually created oxaliplatin, and that trial is ongoing. We don't have those results yet. So we do recognize that it's a very a big problem. It's an important issue that limits our ability to provide adequate chemotherapy to our patients, and sometimes we have to stop using oxaliplatin, even if it is effective, because the patients can't button their buttons, they can't write, they can't walk, they fall at times because they can't feel their feet. So it is an issue, and it is being evaluated.